painless discussion of some of the issues that we do have and that we'd like to bring forward. With regards to my personal disclosures, you've already seen them. I have no financial disclosures to report. And as Vicki said very nicely, kind of our objectives today are to discuss the importance of hypertension and cardiovascular disease. What are some of the best practices that affect hypertension and cardiovascular disease, and kind of aligning this with HEARTS, as well as the other programs that are here in these pieces. And some of you are saying, uh-oh, he got the wrong slides. But I'd like to start, because this is an issue of this region and of the country and areas that we want to focus in and develop, where other types of public health types of conditions and population health conditions have come in. I'd like to do a success story of looking at pellagra. Some folks probably here on the phone, pellagra is just something that is looked at in textbooks. It's a little bit older practitioners will kind of say that they're a little more familiar with pellagra. And if you were 100 years old, you would know it very, very well. And if we were doing this 100 years ago, this is some images of pellagra in South Carolina, but this is pretty much the image. This basically an epidemic at that point in the early 1900s. And this is what that map looked like. This is the mortality map for pellagra. And areas such as South Carolina had these very high, and again, these are mortality rates that we see. And kind of looking at this, at the time, pellagra was known as the disease of the 4Ds, and that would dermatitis that you see there, diarrhea, dementia, and death. And we bring that kind of in, thinking about what we're going to talk about later, and that's hypertension and some of these pieces that seem to fit together. In 1912, the state of South Carolina had 30,000 cases with a mortality rate of 40%. Boy, just imagine, how bad that would be for some of our conditions that we do see now. So this was truly a major population health problem. And as some of you may remember, basically pellagra is from poor diet, basically from poverty being the root of that, not eating, in essence, getting vitamin B and niacin was this piece. At the time, though, if we think about, we needed this basically reform, because most people in the early 1900s, the farmers were planting cash crops, or what they hope would be tobacco and cotton. And so you were not getting that access to the fresh fruits and vegetables that would have prevented pellagra or balanced diet. Again, in the next decade, you basically knew that B vitamin niacin certainly is what was affecting pellagra, which was making things better. They have this amino acid tryptophan from commercial foods, again, fortified foods, and basically could prevent this scourge. What happened in this point, in 10 years, you went from a probably the #1 public health problem to becoming something almost gone. It typically vanished. We share this because we think that maybe this is the idea that we'll do the same thing or do something very similar with hypertension. A little bit more, I know you're probably tired now, we don't need history in the afternoon, but anyway, it's kind of there. Bringing this forward, this same type of capacity. This is the Yalta Convention towards the end of World War II, in which the Allied leadership came together to determine what was going to happen in Europe, how was particularly Germany going to be broken up after World War II. And here you had Churchill and Roosevelt and Stalin. One thing to note there is Roosevelt smoking a cigarette. But right after this convention, this is where it is, President Roosevelt had a stroke and died. And this was the headline in the St. Louis paper. It came out of nowhere. It's clear skies. Like this was a healthy individual. To all of a sudden, he had a hemorrhagic stroke and basically died. It just came. We didn't know anything. Maybe though there was a prediction model. This is Roosevelt's blood pressure levels at the time of his near the time of his death. At D-Day, he was looking at a systolic blood pressure of greater than 200, nearing 250. At the Yalta Convention, where you just had that photo, it was again at the 250, drifting up towards a 300 type of level. Certainly blood pressures that were very, very critical to his overall health. But bringing in now, going from pellagra, now bringing in conditions such as hypertension. If we look a little bit more at, in this particular, is looking certainly at the southeastern region. This was in 1950, and this was done by the U.S. Geology Society, and they were looking for a water source that seemed to be protective against stroke. And you say, well, why would that be? And if you remember the same man, President Roosevelt, he would go to Warm Springs, Georgia, and say, the waters have healed me. I'm feeling great when I go to Warm Springs, Georgia. And so they went to see where are the water sources that protect individuals against stroke. They didn't find that. They found this, what was referred to at the time, the enigma of the Southeast, which was these contiguous groups of counties that began at the North Carolina-Virginia line and carrying through southeastern Georgia. Some of the rates of the highest stroke rates in the world in one sense, but certainly in the United States. So you now go 50 years later, 60 years later, 70 years later, and now this is what this stroke looks like. And I think for most everybody listening today and being with us today, we're all kind of in the stroke belt, or we're in the stroke region where we have high stroke rates, and bring this forward. So this is where we've kind of morphed again into geographic maps, going from something like pellagra that we've eliminated to now going to something like stroke and hypertension that we clearly have not yet. So we have some work to do, but some directions and perhaps a roadmap to be successful and do it. Well, let's do like what we did with pellagra, and that's look at some of the conditions. And I know that most of you know all of this. So let's look and see what are the factors that seem to be playing this big role in the stroke mortality. What can we do, and what can we do to lead and offer some type of a protection type of fashion? Well, this was a hypothetical model that was developed in the 1970s, kind of looking at some of the risk reductions that's associated with blood pressure reduction. And at that time, it was felt that if you could take the population shift and shift that to the left, however you did it, pharmacologically, you lowered blood pressure, you did it with lifestyle, whatever you could do to shift blood pressures to the left by 2 millimeters, you should see a reduction in stroke mortality by 6%, reduction in coronary heart disease by 4%, and a total reduction of all mortality by 3%. Very significant. And you're thinking, boy, I could really do meals. Well, let's take it one step further for an area like the Southeast that we've been talking about with high risk. A 5 millimeter reduction for the population in systolic blood pressure could be a 14% reduction in stroke, a 9% reduction in coronary heart disease, and a 7% reduction in all mortality. This is the evidence. Here was the hypothetical model. Well, congratulations to you. You made this happen. We did that. You accomplished this. This is looking at these blood pressure distributions from the 1960s through the 70s and on up into the 90s. And what this is showing, that with each age group and everything else, you saw a shift in the blood pressure. You saw a movement in the blood pressure of all blood pressures. So the pharmacological therapy that you have employed is making a difference on population health and population shift in blood pressure. But also the consulting with individuals in the population that are not quite hypertensive yet, but are doing lifestyle modifications, losing weight, reducing their salt intake. These lower blood pressures, lower percentiles, were also shifting to the left. So this, I believe, is a tremendous success story, almost on parallel, I believe, with something like Pellagra, where we're working together and removing it. Looking at it in a little bit better fashion, a little more obvious type of thing, the average systolic blood pressure in 1960 for adults was 131. The average systolic blood pressure at the turn of the century, basically 40 and 50 years later, was 122. Remember that hypothetical. We should be seeing a reduction in stroke. We have been. Are we there yet? No, of course not. But we're starting to head there, so we know that we have some very, very positive trends. Another piece that's so important to kind of look at is that you see these improvements in each age group, and you see it, which is there and this. So for the 18 to 29-year-olds, you saw reductions of blood pressure, 6 millimeters over that time period of 18 to 29-year-olds. Again, 11 at the 90th percentile. 30 to 59-year-olds, dramatic differences, 17 differences in blood in systolic blood pressure, all the way up to, and of course, the biggest difference in the 60 to 74-year-olds, probably the best way that they could go, significant reductions in those blood pressures. As we looked at this, we see, if we look at the death rates for cerebrovascular disease, as we saw that shifting in blood pressure, you began to also see the changes that we see in stroke mortality in particular. Notice, you could say, oh, well, it was always coming down. Yes, you're right. It was kind of coming down, but it's kind of jibber jabber there for a little bit. Notice when we made a concerted effort, when we started incorporating guidelines and working together in programs that would lower blood pressure, now you see a smoothing of the reduction in blood pressure. You're seeing that major effect in that lowering that we feel is so very, very important. So showing it just a little bit more in that same geographic population that we saw with regards to Pellagra, bringing that part in, that we see with stroke now. Now let's take a look at those blood pressure shifts that we've kind of proposed. This is some work we did just last year, and looking at what we're calling the 40-year shift. And this probably summarizes, again, very similar, looking at what we saw before. The solid line were blood pressures in the 1960s for African Americans and Caucasians in the Southeast, and the dotted line of what we see in 2005 in that same region of the country. A few things to notice, and again, this is important. One is we're tightening up the belt, that range that you see in how we're looking at blood pressure, that even though it's still a range, we're seeing it. But look at what you have done. You basically, in 1960, this is roughly 10 to 15% of African Americans and Caucasians in the Southeast had systolic blood pressures greater than 200, okay? That place that Roosevelt was, those severe areas that you're being a part of. Look at what you did. You basically have eliminated, here's the 200, where it was reasonably prevalent in 1960 for both African Americans and Caucasians. You eliminated it. You recognized it, you diagnosed it, you treated it, and you managed it, and you reduced those blood pressures down to a more livable type of level. So you did for blood pressure, what we did, you also did with pellagra. You eliminated it. You brought it all through. The other piece that you see, so that's the good piece, you also affected the whole population. These folks that had the lower blood pressures that you really wouldn't have treated pharmacologically still benefited from something because they shifted their blood pressures to this degree. So that might be that reduced salt intake that we did see, and also reducing weight, activity, all the non-pharmacological, the dietary and behavioral things that you think to shift blood pressure. So putting all that together, we've successfully shifted those blood pressures. Have we eradicated all elevated blood pressure? Of course not. We still have a ways to go, but we still have a model that we're able to employ that we can achieve these effects on the population level as well as on the clinical level. The other piece that we show with this is that we saw these benefits in all ages and again in both race groups, in Caucasians and African Americans. In fact, the improvement in blood pressure and the reduction in systolic blood pressure was even better in African Americans at all ages, where it was a larger type of difference. But notice that every category, each age category, and in each of the race groups, you saw improvement in systolic blood pressure. So in one sense, what you're doing, keep doing. We're making a very good benefit. We have a great model, and now let's look and see some of those ways that we can. Well, we want to kind of understand, and I just think that it's important to kind of understand the guidelines and understand the package rather than just hearing the words and kind of going through the motions. And I just thought this was kind of cute. You know, the cashier told me to strip down facing me. And by the time I realized they meant the debit card, it was too late. So a very important piece. How do we engage and how do we understand the guidelines? And I know that you've been picking it. Do these things have impact? Do they work? This is where we're looking at the JNC guidelines, and notice almost with each rendition of the guidelines, we've shown a reduction in stroke mortality, or exactly what we're kind of looking for. So we saw reductions in blood pressure, but also in this case, looking at stroke mortality. So we feel these pieces really are making significant impact and making significant effect. Now look at this too, just one more piece. We say, well, maybe we were learning about blood pressure. No, we knew about blood pressure and elevations from the actuarial reports from the 1920s, where they said the higher the blood pressure, the greater the risk of mortality and particularly stroke. So we've known it for a while that this is a piece. But when we put together things that are like HEARTS and guidelines and whatever they're going to be, target BP, whatever program you're working at, that concerted, planned, systematic action, that's when you see the biggest benefit and the biggest improvement. So now here we are today, and kind of bringing in the importance of doing these aspects and recognizing what the blood pressure is. We have increased the number of people that has to be kind of the burden. You're kind of saying, well, wait a minute, we haven't, even with the older definitions, we haven't managed to control all this high blood pressure. And what are you guys coming along here and all of a sudden making us get even worse? Where earlier on with the JNC7 report, we were considering the pre-hypertension category. And if you had a systolic blood pressure of 120 to 120 or 130 to 139, with JNC7, as you know, it was considered a pre-hypertension. Now, with the newer guidelines and the new categories of blood pressure, now we're saying this is a stage 1 hypertension. This has significant impact, and I can tell you, as someone that was involved in some of these decisions, this was not a decision taken lightly. This was not a bunch of bureaucrats or a bunch of eggheads sitting in a room and saying, I think let's see what we can now do. How can we burden primary care just a little bit more than we're already doing? That wasn't the case. It was very significant thinking. How can we benefit the population, and how can we hopefully do it in a very concerted and positive way? But what we did, we moved all of us from a third of the adult population to now, today, roughly almost half of the adult population would be considered hypertensive. Half of the adult population are hypertensive that are warranting some type of treatment and regimented treatment to lower that. That's a very significant increase. That's a very significant impact on primary care bringing forward. That's been recognized. So we make this statement, these types of statements and these types of categories, recognizing that we want to also provide the tools and the instruments to make sure that we're able to recognize this and to do something about it, rather than just have a not so good report card. So do we have some success models? Lots of them, including yourselves, where you have improved these capacities. This is just one example from Kaiser Permanente that you're probably familiar with to a reasonable extent, looking at the improvements in blood pressure control that they use with a concerted effort, a strong desire in putting it together and develop a hypertension program. And originally, before this program was implemented, if you looked at the hypertension control rates for Kaiser Permanente, they were actually lower than what you saw in other areas of California, and they were also lower than the national rates we're looking. So they really, in one sense, weren't doing so good. They implemented these programs, and what they achieved in a reasonably short period of time is a reduction in improvement in blood pressure control, but it was associated with a very significant reduction in cardiovascular mortality and very significant 42% reduction in stroke mortality. And you say, well, yeah, maybe everybody was getting a lot healthier. Perhaps, but if you looked at what happened with cancer rates, not near as dramatic in this cohort as you saw with the improvements that you saw with blood pressure control in cardiovascular disease and stroke. Feeling very good that this is indeed something that we could do to improve blood pressure control, following these types of best practices, developing a concerted effort and bringing pieces forward. And that's where we kind of bring in this piece with HEARTS. And that's what HEARTS is doing. And I know that you've had some great discussions of the contents of HEARTS and the desire. And I know that you've already heard what HEARTS stands for. So I'm going to probably repeat it, but repeat it very quickly because you want. But programs like this that you're considering as a complement to other things like Target BP, like any of the other packages and programs that you're looking in, it can be combinations or whatever, but bringing all of that together, we think that these kinds of packages can indeed make a big difference in cardiovascular and hypertension management. Remembering your hearts, looking at lifestyle. E for the evidence-based treatments that you'd be using. A is the access to the medicine and technology, the risk-based management that you bring in there for the whole team. The T is extremely important, the team-based, where at one time it's not just one person now, one healthcare provider that does it all. It's the whole team. It's maybe everybody, even in the office, even to the person, the receptionist. Everyone playing a very, very vital role. And then certainly the importance of monitoring. And I know that you've built all of this in, and you build these pieces in, just trying to kind of say that you're on the right road to consider these types of models. I'd like to hit this other, because it's so important that programs like HEARTS can affect the total distribution of blood pressure. certainly it affects the hypertensives, the people with elevated blood pressure, and there's the strategies to do this. But something like HEARTS also affects all blood pressure, the whole blood pressure distribution. And I start out with one that we have, and that's with sodium. And there's some, I guess, some controversy, certainly some debate about what is that magical level that we want to do. What do you recommend? You say don't eat so much salt. Well, me and all your patients are going to say, well, what does that mean? And so you're going to provide some type of a level and how you determine what that particular level is going to be. And there's a lot of debate. Is it 2,000 milligrams? Is it 2,500 milligrams? Is it 2,200 milligrams? Is it 1,800 milligrams? And there's arguments and debates that's there. In this piece, what I kind of show with this slide, or I like to, is it's a little bit frustrating because we don't have anybody that's even close to those, the debated values. Basically saying that most Americans, and actually most everyone around the globe, are eating too much salt. We have an excess amount of salt. And so sodium reduction is a very reasonable part of HEARTS. It's also a very reasonable part of the overall blood pressure control, management, and prevention. Just adding to that, this is looking at those same levels, looking at global aspects of it. And show this because I think it's important. You have recommendations, the World Health Organization, from the American Heart Association, from what I'm part of is the World Hypertension League, and that's generally in these types of categories that you're familiar with, in the 2,000 milligrams to maybe 2,500 milligrams. And the point that you show with this is that there's no country, there's no region of the world that is taking in what we would say the recommended amount of sodium. We're all taking in an excess amount, and every population is. Granted, certainly there are individuals that are on an appropriate sodium diet, but in general, salt reduction is an important piece. It's an important piece of HEARTS, and it's also an important piece of global hypertension control. And as you look at some populations, their intake is 4, 5, 6 times what would be recommended. And so this is a major piece that is associated with that hypertension control and things that we can do to fit. It's also important to remember that, you know, a number of people, they say, okay, I won't add salt to my food. And while that's there, that's a small percentile of where most of our salt comes from. Most of it's coming from our processed and restaurant foods. And that's particularly the case in the United States. And we get a little bit that we put in some of our food preparation. In other countries, it's the food preparation that seems to be how food is prepared. In our case, most of our salt is coming from processed and restaurant foods. So with that, it's important for us to understand what labels are and what are we getting in food. And the point of this is not to do a quiz, and it's not to see who knows what, but in one sense, as we just go through this a little bit, thinking about patients, thinking about the population, thinking about the messages, it's important to get some idea of how much sodium is in here. So we'll take whatever you like. Perhaps you say, I'd like 2,500 milligrams is what the number I'm going to be thinking about and recommending for my patients. So if I were your patient and I came in and I said, doctor, you're great, you know, I appreciate everything you're telling me. I'm now, when I go to Costco and I go to the food court or I go anywhere, this is not to implicate Costco by any means, but I go here and I'm having a chicken Caesar salad. Isn't that great? And you probably say, yes, but then you need to look at me and recognize from that chicken Caesar salad, this is the amount of sodium that's in that chicken Caesar salad, almost that daily quota. And so it's just, we just want to have that some idea, for one, to let me know that, well, this is my daily quota, so the rest of everything else really needs to be pretty low. Also for you to think that if I'm eating lots of chicken Caesar salad, maybe that might be affecting a little bit of my blood pressure, and maybe I need to really kind of focus in on blood pressure reduction. Another one, just kind of fun, telling your doctor I only eat at P.F. Chang's once in a while, but I reward myself perhaps once a week, and I go and I get the double pan for noodles with pork. Sounds very reasonable, looks like a tasty meal. I'm rewarding myself for doing so good with my diet the rest of the time, and I'm taking my blood pressure medication. But I'm having this, and with this one meal, I'm looking at nearly 8,000 milligrams of salt. And again, this is not a quiz on nutrition or anything like that. This is just kind of getting in that, that some of this, I don't know, probably the patients don't know. It's just kind of making an alert that maybe kind of thinking about where we get most of our sodium from restaurants and processed foods, to kind of be a little aware of how we, of what these are, what these values are. And again, just one more. This is just the seafood dish. I love seafood, and I suspect you do too, or some people do. And I'm just looking at that quota that you do see, how much sodium is in these meals that we typically like, and just bringing in just a little bit of awareness, not a restriction, just an awareness. And I show this too because how do we get aware? Well, we read the labels. And this is just bringing in another little piece that as your patients go and talk about it, I don't know how you are, I particularly like a chicken pot pie. And if I looked at that chicken pot pie for myself, that's what I would eat. If you said we're going to have chicken pot pie and you brought it out for me, I would sit there and look at it. So if I look at the label, and you will as well, I look at it very quickly and I see 970 milligrams. Well, that's not too bad. I think that's it. What often is failed to do is 970 milligrams, but it's there's 3 servings there. Now that's, for me, that's not 3 servings. That's 1 serving, but I just need to be aware. I need to understand how to read that label, realizing that it's 3. And so instead of it being 970 milligrams, it's closer to 3,000 milligrams. So again, kind of in that pass, here's my one meal, and it's already kind of at my quota. Just kind of awareness and kind of bringing some pieces forward. So ending at this, these programs such as HEARTS have a great impact. We think about things like stroke. We know that this is now what we're trying to address: stroke, heart failure, end-stage renal disease, things that are really kind of plaguing now our country and our development, and these areas that we tend to see, and this is our direction that we want to go. So our clinical implications, I think, for the blood pressure management and the direction that we're seeing is that the first piece, the strategies that have been developed, such as the HEARTS package, as well as the other pieces that you're doing of looking at blood pressure detection, treatment, controls that were implemented in the latter part of the last century, are effective in patients today and have great impact. And that's a compliment to you for implementing such. Also, with implementing things like HEARTS and looking at this, you have both a primordial as well as a primary prevention activities where you're preventing hypertension from actually occurring, particularly with the lifestyle parts. And most important, this early detection of hypertension using the proper blood pressure measurement, and then bringing in appropriate treatment at the earliest stage that you can be a very, very effective blood pressure control, regardless of any social determinants of health. We can know that we can do this and do it in a very, very effective manner.